shorter lecture. And yeah, we'll, I think I see you guys every day next week. That'll be fun. All right. So think back to thoracic. Okay. What are my two types of pleural effusions? Exudative and transudative. Do you guys remember the answer to this question? Malignancy. Good. Right. When you think of transudative, think malignancy. When you think exudative, think like infection or some other cause. Okay? Alright. So, those were effusions, right? So that is fluid built up around the lung, not in the lung. This is another type of fluid collection that collects outside of the lung, okay? It's called an empyema. And another word for it is a pyothorax. Basically, it's purulent fluid. Okay, it's an abscess. These things are gross. They're not fun. Okay? They basically stick to the wall of the pleura, okay, the thoracic wall, and almost make, it's not going to be like a fluid filled nice, it's not going to be gravity dependent, okay, it's going to just stick and adhere to the inside wall of the thoracic cavity, and the person will most likely be very, very sick. Okay? If you have some other suppurative type of lung disease, we refer to it as parapneumonic emphysema. That's 6% of the cases, but most of the time, Staphylococcus is your #1 cause of bacteria that causes this. Okay, that's what I want you to know. It can also be gram-negative bacteria, though. Klebsiella pneumonia, Proteus species, Enterobacter, Salmonella. Okay, E. coli and Pseudomonas are, if it's going to be a gram-negative, those are the two most common. And then if it's going to be fungal, you have Aspergillus, Coccidios, Blastomyces, and Histoplasmosis, or Histoplasma. Okay, we do have parasites that cause it, but it's most likely going to be almost like a polymicrobial. Okay, very rarely is it just one bug, which is why we have to hit it with IV antibiotics, so it'll be broad spectrum. Okay, the biggest thing is getting source control. Okay. So this is the clinical course of empyema. Okay, so you have some fluid, you have the acute exudative type process. Okay, it's low viscosity, you have a low white count, low LDH, the glucose and pH are normal. Okay, so it's just the very start of an infection. Okay. Between 2 and 7 days, it really becomes like fibrous and like fibropurulent. Okay, the fluid texture becomes more turbid. Okay, white cells increase, LDL increases, glucose and pH decreases. Okay, because the bugs are eating all the sugar. Okay. And then you have that fibrin deposit on the pleural surfaces, making what we call that rind. Remember when I said, when we were talking about like abdominal abscesses, it'll make that rind. It's a thick, fibrous, gross lining of that abscess. Okay. And then if we don't fix it, you know, or get ahead of it before that 7-day mark, anywhere between 7 and 28 days, you're going to have a chronic type of purulent empyema, and it's harder to treat. Okay, the bigger the rind, the harder to treat. The glucose level of the fluid is less than 40. Okay, the bugs love glucose. Okay, so the more bugs, the less glucose. The more bugs, the less the pH. Okay, and then that fibrin deposit thickens. All right. So what do we look for? We look for fever. We look for cough. Right? We look for chest pain, pruritic chest pain, not just like that. You know, it's different than substernal. It's different than you know, chest wall pain. It's pain with breathing. Okay. You may have hemoptysis. You may have a productive cough, like I said. Other signs, they may be anemic, tachycardic, tachypnic. Decreased breast sounds, it may be dull over that area. It should be dull because it's a fluid-filled space. Okay. If it's really ongoing and really chronic, you may start to see clubbing of the fingertips, and then occasionally the pulmonary osteoarthropathies, which basically means that the pulmonary spaces become more fibrous and less resilient. Okay. Most important non-invasive test is a chest X-ray, and you'll see why. I think I have a nice X-ray of it later on in the coming up slides. Right? So plain chest X-ray is the best. It really can help diagnose between either an pleural or lung type of pneumonia or lung abscess or pleural effusion. Okay? Again, you're going to have that D shape on the X-ray on the inside wall of the thoracic cavity. And then that mediastinum can be shifted away from the affected side. Okay, just like with any other space, right? If you have a big enough thing that's not supposed to be there, it can shift things where it's not supposed to be. We want to try to do a bronchoscopy on all of these patients so that we can take and make sure that it's not eroding into the parenchyma, into the lung tissue. If it does, or if it's at least collapsing those bronchioles, we can actually put stents in them to keep them open while we fix it if we need to. Okay, if it's really messing with their, ventilation and oxygenation status. Okay. Now, chest X-ray is gold standard, or chest X-ray is the first really, best image. Okay, non-invasive image. But we do a chest CT with IV contrast on anybody who's suspicious for empyemas. Which, if you look up here, okay, you have this mass, but you can really see the difference of that is you can kind of see those air bubbles in there. It just looks gross. Okay, it's not a nice normal lung tissue like you see on this bottom corner here. Okay, so that is an empyema here. All of this is an empyema. You have those gas bubbles in there. Okay, loculated. Got septums in there. It's gross. If you ever get to see a washout of an empyema, wear some Vicks. Okay, it'll be gross. It's not fun. Okay. All right, treatment. So early diagnosis is really, really key. Okay, early empyemas, the pleural fluid may not actually be frankly purulent. Okay, you'll have that greater than 3 grams of protein, meaning exudative. Okay, that pH will be less than 7. The glucose will be lower. Okay, if you have that fluid, when it gets to lower than 7, glucose less than 40, and an LDH greater than 1,000 is really into that more, chronic stage. Okay, like we talked about. Goals for treatment: we want to treat the infection needing IV antibiotics. Most of these we will not just treat with oral, we will keep them in-house and at least initially and put them on IV antibiotics. Okay, we want to remove that purulent material and have that re-expansion of the lung. That is key. Okay, and then if we can get rid of the underlying disease process, we will, but most of the time we can do this by IV antibiotics and getting source control. Okay, meaning either doing a VATS, which is sticking the cameras in the chest, or opening the chest, like thoracotomy, and actually washing out that area. Okay. So initial treatment is at close to thoracotomy, trying to get into that space. Okay. If we don't really have good therapeutic, adequate therapeutics, like their fever is still going, they have a really bad cough, their white counts are still super high, we're not really getting much out of that chest tube because it's organized, okay, it's thick, then we try to do a CT scan, and then if we need to do open drainage, they have that VATS for open decortication and washout. Okay, this is a good slide for FYI. Okay, it's everything that we've already talked about. It's just in a chart form if you like charts. I will not test specifically from this, but everything on this chart is something that we've already talked about. Okay. So lung abscesses are different than empyemas, okay? These are within the parenchyma, in the lung tissue, okay? This is how you differentiate between empyemas and lung abscesses, okay? Empyemas are outside the lung abscesses are inside the lung, okay? Now, when you have the difference between a primary and a secondary lung abscess, okay? So primary is the previously healthy individual, and they aspirated, they developed pneumonia, and then it turned into a lung abscess. Okay. Secondary is they have an underlying cause. They have some sort of obstruction, so like a tumor or hilar lymphadenopathy. They have necrotizing pneumonia. They have chronic pneumonia, opportunistic infections. They may be HIV positive, leading to those opportunistic infections. Okay. Usually, the underlying cause is necrotizing pneumonia. Usually, okay? Because we need that liquefaction necrosis of the lung parenchyma to actually form this abscess. Symptoms, pretty much the same. Cough, fevers, putrid sputum, hemoptysis, dyspnea, pruritic chest pain, but you also have that weight loss now. Okay? On the chest CTs, okay, you'll have it in the actual lung parenchyma, so you have tissue around it. Okay. You'll have consolidation, it may have a fluid level, clubbing, okay, pleural effusions, so it may be in conjunction with a pleural effusion, which is why CTs are really good. Cachexia, and rarely they can kind of erode through the chest wall, and you may actually have a draining chest wound. Okay. Abscesses, because it's a liquefaction necrosis, is actually worse than an empyema. Empyemas are, you know, nice and consolidated. They don't really erode. There's not really any liquefaction. There's not really necrosis there. It's just infection. Versus an abscess, think like it's eating the tissue. Okay. So we want to do a chest X-ray and a CT so we can differentiate between empyemas and abscesses. You're going to have a cavitation, okay? You're going to have that ball-like thing, okay? All right. Lung abscesses, we want to do therapy, right? We want to do IV antibiotics. We want to do aerobic and anaerobic coverage for about 4 to 6 weeks. So these people will most likely go home with a PICC line, okay? Once we get them with source control and, their fevers are controlled, that kind of thing. In terms of percutaneous drainage, we kind of, it depends, okay? I know it says that if patients who do not respond, we do percutaneous drainage. We let the antibiotic start to work and see if we can get this to shrink on its own before we do invasive procedures, okay? But if we can't and we really need source control, then we will put a pigtail, okay, like a smaller bore chest tube in, and try to do, most likely it'll be by IR. I think it'll be under CT guidance to make sure that it's actually in that lung parenchyma, in the abscess, okay? We normally see complete resolution within 3 to 5 months. They will absolutely need chest physiotherapy. Okay, they'll need to do some postural drainage, so laying forward. When I say chest physiotherapy, that's like that chest pulmonary toilets, that vibration, or the trying to break up the mucus in the actual lung itself. All right, so when do we go to the operating room? When we have no improvement in 4 to 6 weeks of IV antibiotic therapies. Okay. So they don't get better clinically, and they don't get better on X-ray or CT. After 4 to 6 weeks, we will go in and either do a VATS, which is that, like I said, that camera, okay, laparoscopic thoracic surgery, or we'll do an open decortication like we would with an empyema, and so the same treatment. Okay, if we need to, this is the one where we may have to take a lobe of the lung if we need to. Okay, depends on how bad that abscess is. So, empyema. Adheres to the wall. E-shaped. Football shaped. Okay? Pneumonia. It's fluffy. It's in the lung. Abscess, cavitation. You have a fluid level inside the lung. Does everybody see the difference? I would know how to spot the difference. Okay? Alright. Lastly, we're going to talk about neoplasms of the lung. Lung cancers, one of the most common cancer-related deaths in both men and women in the U.S. 85% is caused by smoking tobacco. So don't smoke. Okay? Normally, after 5 to 6 years of smoking cessation, okay, so when you stop smoking, your risk exponentially declines. After 15 years, it actually approaches to levels of that of non-smokers. But this is why you don't smoke with your kids in the car. Secondhand smoke increases your chance of getting lung cancer by 2 to 3 times. So don't smoke in the car with your kids or with anybody. Okay. Exposure to asbestos, pretty high up, 23% of all lung cancers. This is why we ask even retirees what they used to do. Okay, shipyard workers, railroad train workers, okay, truck drivers, cement makers, plumbers, anywhere that they might come in contact with asbestos, they're at risk. Okay. 80% of all lung cancers are from squamous cell cancers, large cell carcinomas, and adenocarcinomas. So those are non-small cell. That's what I was getting at. Okay, so squamous cell carcinoma, large cell carcinomas, and adenocarcinomas are non-small cell carcinomas. They are 80% of all cancers. They're all lung cancers. Okay? When we get into small cell carcinoma, that's about 15 to 20%. And then we always have to come back to our carcinoids, okay? And our bronchial gland adenomas, those are about 5%. This chart is, I'm not going to necessarily ask you percentages, but it's good to know that when you're looking at CTs and you're looking at something that doesn't look right, okay? If it's centrally, it's most likely going to be small cell carcinoma. If it's peripheral, it's most likely going to be adenocarcinoma. Alright, so what are the two differences between central and peripheral tumors? Okay, central, you're going to have local effects. So central, you're going to have, it's more so in the middle of the lung parenchyma, closer to the hilum, okay? So you're going to have cough, you're going to have hemoptysis, difficulty breathing, pain, you may have recurrent pneumonias. Versus if it's peripherally, okay, on the pleural wall, you're going to have cough, chest wall pain, pleural effusions, pulmonary abscesses. This is where we start to see Horner syndrome and that Pancoast syndrome. Okay. Horner syndrome. I talked to my small group yesterday. Horner syndrome. Okay. I would know Horner syndrome. The PANCE loves to ask this question. Okay. If you have ipsilateral mitosis, ptosis, and anhidrosis, okay, so drooping, your eyelids drooping, okay? You have sweating on that side. That's Horner syndrome. Your number one diagnosis to rule out is a Pancoast or a superior sulcus tumor. Okay? If you have somebody come in with Horner syndrome and you do not rule out and do a CT of their chest with IV contrast looking for that Pancoast tumor, you are wrong. It may not be that, but that is your number one primary diagnosis until you know otherwise. So when we have regional spread, okay, that's when we start to see the hoarseness from the lingual nerve paralysis. We could have dyspnea due to phrenic nerve paralysis, dysphagia from compression of that esophagus, okay, if it's centrally. We can have superior vena cava syndrome from compression or invasion of that superior vena cava, okay? And then pericardial tamponade. Okay? That's if it starts to spread or gets bigger. Metastasis is a big one, okay? Anorexia, weight loss, weakness, malaise. In terms of distant metastasis, it loves to go to bone, loves to go to liver, okay? Also loves to go to the brain. So we look for jaundice, okay? We look for bone pain, we look for tremors, seizures, new sort like altered mental statuses, okay? Neurological defects, okay? All right. So when we're talking about where it is, okay? So A corresponds to picture A. Okay, central is touching the bronchus. Okay, it's in the middle of the parenchyma. Cough hemoptysis when you have peripheral. Okay, that's B. That's more on the outside. Okay, B is more likely going to cause that erosion into the chest wall. Okay, you're gonna have pleural chest pain. You're gonna have that Pancoast tumor type syndrome. Okay. C is when it starts to invade and compresses into that bronchus. So you may have atelectasis. You may have difficulty breathing. And then when it starts to, when it's in the mid-parenchyma, you may have either asymptomatic or a combination of all of the above, depending on how big it is. Okay? And then again, the paraneoplastic syndrome, the carcinoid tumors, is going to be caused by either reduction or depletion of whatever hormones it's doing. So you may have clubbing, you may have proliferation of those growth factors. Okay? Those are, again, all, like 5% of all cancers, so it's pretty rare. Okay. So in terms of these, basically I want you to just know, like, if you have a paraneoplastic, you may see somebody who has SIADH. If it's small cell, if it's squamous large cell or adenocarcinoma, you may have that hypertrophic pulmonary osteoarthropathy. Okay? And if it's a carcinoid, it's just carcinoid in small cell. So those are three kind of things that you can actually, if it is a carcinoid type tumor, or if it's a, like what you could potentially see depending on what type of tissue tumor it is. Just know those three boxes. Okay. So, going into the small cell, sorry, the non-small cell lung cancers, okay, you're going to see hypercalcemia. It loves to go to the bone. Loves to go to the bone. Okay, so it's going to be leaching out calcium, so you're going to have hypercalcemia. Okay, with small cell lung cancers, okay, it's going to be like an ADH, so antidiuretic hormone. Okay, if you have SIADH, your sodium is going to be low. If you have MSH production, that I forgot what it is now. I think it's nicotine secretion hormone. You're going to have hyperpigmentation. Okay, and then ACTH production, you're going to have increased cortisol, you're going to have a Cushing syndrome type picture, and then the glucose intolerance. Then adrenal insufficiency, fatigue, salt wasting, or salt craving, weight loss. You may have that electrolyte imbalance, hyponatremia, hyperkalemia. Okay. But the biggest ones are the small cell, non-small cell hyperkalemia, small cell ADH. Alright, talking back on that Pancoast tumor. Okay, these are the lung apexes. Okay, it's going to look it's not cavitized, it doesn't have a fluid level. okay? It just looks like a mass, a fluffy mass within the apex. Pneumonias don't normally like going to the apex. Can it happen? Yes, but normally not. Okay, so if you see a fluffy mass like this on the apex of the lung, I would not jump automatically to pneumonia. I would jump to Pankos until you know otherwise. So, permeating lung, invading the chest wall, okay, at or above the second rib. You're going to have impingement of the brachial plexus, this cervical lymph chain, and superior vena cava. So you may have an arm swelling, okay? You may have mitosis, ptosis, and then you may actually have what, like, even a Bell's palsy type picture, okay? And then again, just in case anybody didn't know what SVC, that superior vena cava syndrome is basically an obstruction of that, and so you're gonna have swelling of the face or arm on that side, especially when the patient lies flat or bent over. Okay, if it's so bad, it's just swelling and it's causing that obstruction from getting the blood back from that arm. It may be kind of chronic, but it's more pronounced when they either lay flat or bent over. All right, what labs can we do? Okay, we really want to know serum alkaline phosphatase. Okay, that is a bone marker. Okay, if elevated, if you have neurological symptoms plus bone pain, okay, you have to do a bone scan and a brain CT. Preferably an MRI if you can, but bone scan, so like a DEXA scan, and either that or a PET scan, and then that brain CT. Okay, most likely without contrast. If we find any abnormal findings on the chest X-ray or they have any pulmonary symptoms, we're going to do most likely a chest CT with IV contrast. You can see there's a nice big tumor there. Given that it's the apex and peripherally, well, you can't even say if that's peripherally or centrally. It's so big that we don't know where it originated from. You'll see up here, right, you have this circular mass, but it's kind of empty. There's no fluid in it. If there's no fluid in it, there's none of that liquefaction of necrosis happening. Okay, so it's more likely a solid mass. So other than the bone and brain, it also likes to go to liver and adrenal glands. Okay. A PET scan is really critical for staging in terms of like where is this spleen. And then we'll do a thoracentesis if there's fluid to see if it's a malignant thoracentesis or malignant pleural effusion. Okay, and then we can do a thoracoscopy or whatever we need to do in order to get that pleural effusion out for testing and patient quality of life. Okay, so you have a neoplasm or you have a nodule in the lung. Okay, initial finding on a CT or chest X-ray. They come and see you kind of after, it's what we call like an incidentalloma. We weren't looking for this, but they found it. What can you do in order to figure out initially if it's benign or malignant? Okay, these are pretty easy. Okay, so if it's less than 2 centimeters and it's stable, meaning it doesn't get any bigger over 24 months, so 2 years. So these people, you are not just letting them go for 2 years, right? It's chronic, probably every 3 to 6 months, at least chest X-rays or CT scans to really observe and trend that patient. Okay, if they have concentric calcification, it's a smooth border, it's a solitary lesion. Okay, like you see down here, nice smooth, versus up here, it's very erratic. Okay, it's spreading, versus the one down here is nice and smooth. So smooth versus erratic. Okay? So if it meets those criteria, most likely it is benign. Okay, if the patient is still freaking out, you can still send them to get a fine needle aspiration. We'll get into that. Okay, but if they have those, you can pretty much say it's most likely benign. After 2 years of observation, it hasn't grown any bigger than 2 centimeters, probably benign. But if it's greater than 2 centimeters already, or increases in size, it's becoming unstable over the next 2 years, as regular calcifications, as spiculated, irregular border, and there's multiple of them, more than likely it's malignant, and they need to go see an oncologist. Okay? So those are just very easy, like, things to remember, to be like, yep, it's less than 2 centimeters, it's very smooth, it's stable, it hasn't gotten any bigger in 2 years, we can watch it, but most likely it's benign. Okay? If it's not that, then you need to do more. Okay, so we can do sputum cytology. And this is a deep cough. This is the really deep, gross. You want to get that lung butter. Okay, that deep, deep cough. Okay, it's not just spin. All right, you gotta get them. You gotta do it. Right. If they can't do that, then we should probably set them up for a bronchoscopy. Okay, where they're in twilight, we stick a camera down into their lung. We can take brushings of that area if it's centrally. Okay, we can do washings of that area to get that nice lung butter sputum. Gross, my kryptonite. We can also do a transbronchial biopsy. Okay, so when we're down there doing bronchoscopy, we can actually, if it's close enough to the bronchial wall, we can do biopsies through the airway. Okay, and then we have that transbronchial ultrasound. Okay, so instead of an EUS, what we do for the pancreas, right, or any esophageal type ultrasounds, it's going to be a BUS. Okay, it's going to be fine. We can do fine needle aspirations as well for mediastinal nodes and masses that we see within that ultrasound. Now, when you think about percutaneous or transthoracic biopsies, this is coming from the outside in. These are done by IR. These are done under CT guidance. Okay? It can either be a fine needle or it could be a core. And then if it really is bad, we can do a wedge biopsy of the lung, which is what this is. Okay? We have the mass here at the top, and we basically just took that whole lobe in the operating room. So this is not going to be under a VATS. This is going to be open surgery, okay, thoracotomy, and taking that lung so that we can get the whole lobe. All right, vocabulary. There is a difference between unresectable and inoperable. Okay, so unresectable means that the tumor has evaded or invaded enough vital structures that we cannot remove it. Okay. If it's inoperable, the patient is unstable. Okay, the patient won't actually survive the surgery. Okay, so just know those are two, they're not interchangeable. All right, pre-op assessment. This is nothing new. Okay, we want to know the patient's performance or functional classification. Advanced age alone is not a contraindication. Okay, because we're dealing with the lung, they have to have a cardiac workup. Okay, and we want them to at least have an EKG. If they have any history of cardiac symptoms or an abnormal EKG or suggest anything that suggests an ischemic heart disease, they have to go do a stress test. Okay, we're going to be putting their cardiovascular system under a great deal of stress when we have to drop a lung in order to do what we need to within that chest cavity if we go to surgery. Okay, so if they have any sort of like inkling of they may have some cardiac issues or any abnormalities on their EKG, just send them for a stress test. Anybody who has significant coronary artery disease, okay, one, they should already be under the supervision of a cardiologist, okay? But we also need to have that treated prior to us doing any surgery. Like I said, when we drop a lung, it puts a significant amount of like medical stress, not like compression stress, but it's like their body, it really takes a toll on their heart. So if their heart is already diseased, okay, we need to try to optimize that before we go in and do any sort of pulmonary resection. Okay. So if we want to do a standard resection, if they have significant pulmonary hypertension or if they've had a heart attack within 3 months of that surgery, they're not going to be able to get that surgery. Okay, they really have to be optimized in order to survive this type of surgery. Okay. We want to know what the pulmonary function is, so they have to go see a pulmonologist to get that PFT. Okay, it's not just the peak flow meter; it's actually sitting with that tube and actually doing spirometry and diffuse capillary. It's a whole big thing that you learned in pulmonology. Okay. We may have to do a ventilation perfusion scanning. That's that BQ scan. You remember that from radiology? Think back a few semesters ago. Okay, BQ scan. That's going to tell us if that mass is big enough or is putting enough stress on the lung that the ventilation oxygenation is not working correctly. Okay? Alright. Alright, what are we going to do? Okay, we can always observe. Depends on what is actually happening. Okay? Are they too advanced and we can't actually do anything? If it's really, really small, right, it's less than 2 centimeters, we don't know, right? We could either do a fine needle biopsy if they have a high risk of like they've smoked for 85 years, okay? Or if they have a high family history of lung cancers. Most of the time, we just observe and wait and kind of see what it looks like. Okay, when it gets to that above 2 centimeter mark, we don't wait. We just go do things. Okay, we can do conservative supportive measures. So if they have chronic pneumonia because of this, we can put them on chronic antibiotics. Okay, we can put them on steroids. If it's a carcinoid, we can do a thoracentesis, trying to pull out that malignant effusion. We could try excision, depending on where it is, how big it is, if it's invaded anywhere. We can either try to do that through a VATS or a thoracotomy with that wedge resection. Okay. There are some people that if they're riddled, we can actually take out their entire lung. Okay, so then they're just working on half a lung. Well, not half a lung, one lung of the two. Okay, so that, remember, if you only have one lung, your heart is working a lot harder. So that's why having that optimization of the cardiac system is really, really key. Okay. There are some times in which, if we do neoadjuvant, meaning pre-surgery, okay, we're trying to either do chemotherapy or radiation to shrink that tumor, try to get it to where it is resectable. Okay. Adjuvant is just, we do the surgery and then we do chemotherapy afterwards. If it's a small cell carcinoma, chemo and radiation is the primary treatment. Okay. Okay. And then tumor staging, I think you've seen this a million times. Yes, close to a million. Do I need to go over this? So the biggest thing I want you to know is the higher the T size, okay? So if it's a T4, it's invaded mediastinal organs. Okay. So the bigger the size of the tumor, the more invasion it is, the higher the T. Makes sense? Okay, you have a 62-year-old man who's a heavy smoker. Presents to the with general malaise, occasional cough, weight loss of 10 pounds over the last 2 months. He does not report any travel, recent infections, or use of any medications. He does have borderline diabetes that he controls with diet. Examination reveals that he has some peripheral mild edema in the extremities, clubbing bilaterally. Blood work shows mild anemia, and sodium of 122. What do you want to do next?
That's okay.
Who wants 1? 2, 3, 4. There is no 5. Good. So yes, we want to do that chest radiograph. Okay. What's next after chest radiograph? Chest CT with contrast. Good. Okay. That is thoracic. Let's go to, any questions on thoracic? Nothing burning? What time did we start? 20? Do we want to take our 10-minute now? Because we only have, we have 40 slides-ish to get through with hernias, which is probably 38-ish overall. You want to take your 10-minute now? I'm seeing a lot of head nods. Yes, go take your time. So, any burning questions for thoracic? That will not be the last time you guys see thoracic. We'll do a whole other block on just trauma to thoracic, okay? Which you'll get again in EMED too. So, like, we're gonna get it all around. But now we're gonna switch gears to hernias. Okay, hernias is a very big portion, kind of almost bread and butter almost of general surgery. Okay. There are many different types of hernias depending on where they are, okay, and what caused them. So we're going to go through it. This is just a really good, brief overview of just a remembrance of like, okay, umbilical, it's at the umbilicus, it's at the belly button, okay. If it's indirect, it's more medial. If it's direct, it's more lateral, okay. So just a little bit of an overview. All right, those are our objectives. All right, when we talk about anatomy, okay, we have to know the layers of the abdominal wall. Super important. Okay, so you have to know that right around the umbilicus. Okay, well let's go back. So above the umbilicus we have the linea alba. Okay. And we have fascia, okay, this aponeurosis of the transverse abdominis, okay, that goes behind the rectus muscle. Okay, so there's fascia behind the rectus muscle. But once you get down to about the belly button, okay, all of that fascia is in front of the rectus abdominis. Your 6-pack. Okay, so that is a very big, important location. If we're talking about above the umbilicus, it has to go through a little bit more versus below. Okay, that's just a big overall thing for anatomy. Okay, so when you look at it, you have the skin, you have the subcute fat. Okay, if it's above the umbilicus, like here, okay, you have the muscle going, or the fascia going all the way around. You have the muscles, okay, that blue is that fascia, it's a thick, tendinous type of material. Okay. It does not necessarily like a tendon or ligament, okay, it is basically to connect muscle to other muscle, make compartments. And then you have the peritoneum on the inside of the belly. When we talk about certain hernias, knowing where the linea alba is very important. Okay? You really don't have a linea alba below the belly button. Okay, so when you have certain types of like diastasis recti, it's above the belly button because that's where the linea alba is. We'll get into it. Okay, but knowing where the layers are is very important. Okay, so again, different locations in terms of where hernias happen. We will go through some of them, not all of them. Okay. This is really good when you're talking about the layers of the skin all the way through. Okay, it's just a little bit of a different view. You can kind of see, so you have the skin on the outermost, then you have Camper's fascia, Scarpa's fascia, Okay, you'll hear that a lot when you're in your general surgery rotation and you're doing hernia repair, open hernia repairs. Okay, this is good to know and to show, like, really impress your surgeon that you know the layers of the tissue for an open hernia repair. Okay, external oblique, internal oblique, then you have the transversus. Okay, if it's above the belly button, you have that transversus fascia behind it. Peritoneal patch, then peritoneal. So again, just a different view of those layers. Alright, definition time. What is a hernia? Okay, it is a protrusion of some sort of tissue. It could be intestine tissue, it could be just fat tissue, it could just be fluid tissue, okay? But some sort of tissue through a fascial muscular layer, okay, designed to contain them. Okay, so it's a defect somewhere. Okay, where it's a defect in the fascia, defect in the muscle, a defect in the inguinal canal. Some sort of defect is there causing this protrusion of tissue through it. Okay. Now we go into where. Okay. If it's an inguinal hernia, okay, it originates above the inguinal ligament. Our bread and butter. These are what we see all the time. 96% of all inguinal hernia, or of all groin hernias, are inguinal hernias. Some sort of hernia, or inguinal hernia. There's two different types we'll go through. The next type of groin hernia is the femoral hernia. This is below that inguinal ligament. Okay? Accounts for the other 4% of groin hernias. They are not very common, but they can be very, very dangerous. We'll go through it why. Okay? You have incisional hernias. Those are stuff that we have actually cut into the muscle. We have disrupted that fibrous material. Going through that fibrous material, okay, we caused that disruption. We caused that defect, and it either ripped our sutures out or it got bigger, and now we have an incisional hernia. Okay? Ventral. Okay. This is different than a diastasis recti. Okay? This is an actual separation above the umbilical. There's a few different types of umbilical hernia or ventral hernias, depending on location. Okay, the most common one is probably the epigastric hernia. But ventral is anything midline above the umbilicus. It's just a class, just like groin hernias are a class, ventral hernias are a class. But it has to be midline, okay, and it has to be a defect within the linea alba. Not a stretching of the linea alba, but a defect, a hole. Okay? You have umbilical hernias, pretty self-explanatory, it's at the umbilicus. Okay? Spigelian hernias are through that lineus semilunaris. So if you kind of look here, that area on the edge of your six-pack, between your six-pack and like the rest of your abdominal core, okay, that's your linea semilunaris. Those are where those hernias happen. Okay, so on the outside of your, just on the edge of your six-pack. And then your traumatic hernias, as the name suggests, it comes from a traumatic type of experience. Most of the time, it happens along the flanks, okay, where the muscle is the weakest, okay, right along the iliac crest. Okay. Basically, there was enough abdominal force that caused the muscle to be ripped from the bone. Okay, and I'll show you pictures of those. More definitions. Okay, there's a difference between a retractable, incarcerated, and strangulated. Okay, if reducible. Sorry, if we can reduce it, or the patient can reduce it, that's good. The hole is big enough that whatever tissue is coming through can be reduced back into the belly. Okay, incarcerated, not reducible. Okay, but it is still getting perfusion. Strangulated, you have to be incarcerated first, and then when you get to that point where there is from swelling or that hole is just too tight, you lose that blood flow, it becomes ischemic. That's when it becomes strangulated. Okay, that's when bowel dies. Or fat dies. Fat can die. Okay? Everybody understand the difference between reducible, incarcerated, and strangulated? Those are extremely important. I would know those. Okay? Now, congenital versus acquired. Congenital from birth. Okay? It happened, there was some sort of defect from the fetal development, and so it's congenital. It happens from birth, from the fetus, it just happens. A lot of our baby umbilical hernias are congenital. Okay? When we talk about acquired, it is either from trauma or from ascites or from something that defected the muscle and the fascia tensile strength, so it made it weaker, causing it to have these happen. Okay? It can either be idiopathic, not idiopathic, etrogenic, meaning we did it with those incisional hernias, or from something that the patient is doing, whether it's ascites or Olympic weightlifting, some sort of, it's already kind of had that defect, but it didn't have a defect already. They did something in order to make that defect occur, and then it over time becomes weaker. Okay? All right. Going through the groin hernias. There's 3 different ones. There's 2 inguinal hernias and 1 femoral. Okay? Indirect and direct are a little hard to remember. Okay? But basically, think of it kind of backwards. Okay? You have your inguinal canal. Okay? You have an internal ring and an external ring. Okay? If you remember. Okay? Your indirect goes through that internal ring. Okay? It is lateral to your epigastric veins and arteries. Lateral to it, so it's towards the outside. Okay? So when you think indirect, technically it goes directly into the ring from the ring opening. So backwards. Whoever needs these, I don't know. Okay? But direct goes through the wall. Okay? And I have another picture on another slide that it kind of goes over that a little bit more. Okay? You have the Hasselbalch's triangle, which I have the next slide, I think goes over that. Okay? But it goes through this wall. Okay? It doesn't go through the opening of the inguinal canal, it goes through the wall of the canal. So it's actually indirect. Okay? Backwards. It is weird. Okay? I don't know who named them. But think indirect is lateral to the inferior epigastric veins and arteries. Direct is medial to those veins and arteries. Now, all above the inguinal ligament. Okay? Does that make sense? Kinda. Okay. Now, when we get to femoral arteries, this is underneath, so below the inguinal ligament. Okay? We have that area where we have the femoral artery vein nerve. Okay? It's a little bit of a weakness within the muscle. There really is no muscle covering it. So it kind of slips down below the inguinal ring and you have a femoral hernia. Okay? Alright. Any condition that chronically increases the intra-abdominal pressure can produce these hernias. Okay, that's why these are the most common. Inguinal, like I said, 96%. Femoral are 4% of the groin hernias. Alright, so what is the Hasselbalch's triangle? I would know this. Okay. This is slightly different than the last picture. This is of the right hip. This is of the left hip. Sorry, I couldn't find pictures that match. Okay? So you have your epigastric vessels. Okay, your inferior epigastric vessels. Okay? That makes up the lateral wall. Your medial wall is your lateral border. of your rectus muscle. Okay? And then your inguinal ligament is your inferior wall. Okay? It makes a triangle. This is your Hasenbeck's triangle. This is where direct hernias come from. Okay? So when you see Hasenbeck's triangle, think direct. Okay? Does anybody need to have me go over this again? No? Cool. Alright. So, when we're talking about direct inguinal hernias, so not indirect. We're not talking about Hasenbeck's triangle. This is outside Hasenbeck's triangle. This is lateral to it. Okay? It's normally from a congenital hernia, from a patent processus vaginalis. Okay? It's a fetal remnant. Okay? There's a little defect there, and so it allows contents, whether it is abdominal fluid or intestines, fat, to go through that inguinal hernia or through the inguinal ring, okay, and actually travels down with the spermatocord. Okay. So these are the ones that actually end up with intestines and fat and whatever inside the scrotum. These reach the scrotum. Okay. Presentation, you're going to have either a bulge in the groin, bulge in the testicle, okay, maybe acute or chronic. They may have abdominal distension, nausea, vomiting if it's becoming incarcerated and moving towards strangulated. Okay? Alright, so you have your parietal peritoneum, okay? You have your epigastric, inferior epigastric, these are lateral to them. Then you have that processus vaginalis, okay? It's patent, therefore it can go down through the canal. Now direct, okay? These pass through the wall, okay? It puts pressure the wall of the actual canal, not the ends, not the internal or external rings, but the actual wall, okay? That is weak. And so these are medial, these are within the Hasenbeck's triangle, and they protrude through the wall, okay, of the inguinal ring, inguinal canal. Okay, so medial to the epigastric, and they do not pass through the deep inguinal ring. They don't. Okay, it's never that bad. They will never have intestines inside the scrotum. They will never have increased fluids within the scrotum. Okay. So you can see the difference between it being above the inguinal canal, okay, more medial, and it's more of a bulge versus early, I mean, I know this is a baby, but it's more so either lateral, okay, and into the scrotum. Okay. All right, so you can kind of see here, does not go through the actual ring, okay, does not go through the canal, it goes into the wall of the canal, okay? Does everybody understand that? Do you need me to make a better, like, metaphor? Think of a cannoli, right? Cannoli, if it's indirect, it's going to be through the filling. Okay? If it's a direct, it's going to go through the wall, through the crust. Does that make sense? A little bit better? Cool. Just came up with that on the spot. Love it. Alright, so when we're talking about direct, what can cause a direct? Okay? Obesity, pregnancy, heavy lifting, chronic coughing, straining to voids when you have benign prostate hypertrophy or prostate cancer, constipation, cirrhosis with ascites. Okay, you're going to have a bulge in the groin. Again, can be acute or chronic. You may have abdominal distension, nausea, and vomiting if it's becoming incarcerated and strangulated. Okay? It normally does not extend into the scrotum because it does not go through the canal. If it's acute and non-reducible, okay, if those muscles around it are really tight and it gets stuck, okay, that is an a surgical emergency. Okay? Any time you have incarceration leading to strangulation, if you or the patient cannot reduce it, most likely will end in emergency or urgent surgery. Okay? All right. How do you find it? Physical exam. Okay? You guys will get good at doing sports physicals. Primary care PAs, sports physicals are just a way of life. Bread and butter. Okay? If you are not checking for these hernias, you're not doing a great service to that patient. Okay? So you're gonna do you're gonna look at it standing, supine, coughing, and straining. Okay? Have you guys seen this before with peds? Have you gotten to this yet? Okay. Can happen on any age range. Okay, babies are a lot harder because their rings and their nails are a lot smaller. But you can do this on anybody. A lot of times we do it on sports physicals because they're going to be either lifting weights or doing something that is increasing their abdominal pressure. So we want to make sure that we are catching these early. Okay. With a gloved hand, okay, you're going to be sitting in front of the patient. Okay. It's weird to be eye level, but you kind of have to be. Okay, when you're doing it, you're going on the opposite side. So if you're trying to do their right side, you're using your right hand and going up their right side. Okay, when you're doing the other side, you're doing the other way. Because you want to go up the canal. Okay, if you try to go up the canal with the same arm on the same side, it's going to be funky. Okay. So cross to actually feel, okay? Because what you're going to do is when you actually put your finger up through that canal, okay? If you feel something at the tip of your finger, it's more likely an indirect hernia. If it's pushing against the side of your finger, it's going to be most likely a direct hernia, okay? Because you're actually going up through that cannoli, okay? This is also how you reduce an indirect hernia if you need to. Okay, you're pushing up through that canal. Does that make sense? Okay. When you have them cough, have them turn their head away from you. Okay, don't have them cough as you're doing it directly at your face. That's just be nice to you. Okay. Okay, you can have them Valsalva, but normally it's you are sitting, you feel up the canal, you have them turn their head and do a slight cough, and it increases their abdominal pressure just enough that you can actually feel if there's a bulge or not. Okay, but yeah, don't always have them turn their heads so they're not coughing directly at you in the face. Okay, does that make sense? Okay, you should also be doing a full testicular exam. Looking for masses, looking for, because they're coming in for a bulge or pain in their groin. Okay, if you are not doing a testicular exam, you're not doing a full groin exam. Okay, you want to look for everything that you learned in urology on testicular stuff. Okay, masses, little blue spots, looking for epididymitis. Okay, you're looking for, there's a bunch of differentials that we'll talk about at the end of the lecture when we get through actual hernias. Okay. But you're looking for all of those things to exclude, because most of the time you're actually not going to feel anything. Right? Sometimes you will. There's going to be those patients, but most of the time you're not going to feel anything. So if they're coming to you with pain, you really have to do the full eval. Okay, and that means testicular exam and most likely a rectal exam. Okay, you have to rule stuff out before you can move on. Alright, so imaging. Groin ultrasounds are the initial diagnostic modality. Okay, you're going to throw an ultrasound on there. You're going to learn this in EMED if you haven't already. Okay, you're going to throw it on there and actually see the ring, see where that intestine is. Is it in the ring? Is it going through the wall? Is it below the inguinal canal or inguinal ligament? Okay. So ultrasound is your initial modality. KUB plus or minus And then as your second line imaging, you're doing a CT abdomen pelvis with IV contrast. Okay? Because if you can't see something on ultrasound, more than likely we'll see some sort of defect in that wall on the CT. Okay? If you see it on the ultrasound, you feel it with your finger. Okay? It's not reducible. Do you need a CT? You've proven it on ultrasound and exam. You don't need to have a CT. Well, the surgeons sometimes do it just for surgical approaches and figure, like maybe it's bilateral, because we'll get into that. Okay? Most of the time, though, if it is incarcerated and above, so incarcerated or strangulated, they're coming in with pain. You cannot reduce that hernia, and you can feel it, you can see it on ultrasound. Most of the time, they're just going to take the surgery. You don't necessarily need to have that CT. If there's time, sure. Depending on what the surgeon wants. Okay? Alright. So, when do you refer to surgery? Okay? Routine if it's reducible. If we can support those symptoms either with a brace, like an abdominal binder, if it's more like a groin binder, there's special underwear that really puts pressure on those areas to try to keep it reduced. Okay? So that's a routine. If you feel a hernia, they should go to surgery. Okay? Initial thing, they're not symptomatic, or they're maybe symptomatic, a few, but they're not incarcerated, they're not stuck, they're not strangulated. It could be a routine referral to surgery. And this is to general surgery. Okay? If it's strangulated and or incarcerated, they go to the ER. If you're already in the ER, you call surgery for an emergent consult. Okay? Time is death. Time is tissue death. Okay? So the longer that bowel wall is strangulated and not getting blood flow, okay, the more drastic measures we're going to have to do, and the more likely we're going to have to do an EXLAP and actually open them up. Okay, and then actually take out bowel and hopefully be able to put it together at that time. Okay, but they're going to be sick. If it's strangulated, they're going to be sick. All right, so when we talk about the routine elective hernia repairs, there are some things we want to try to control and to optimize before we fix them, because if we don't fix these, it's just going to reoccur. They're still going to have issues. Okay, so the first one being that prostate hyperplasia. Okay, most commonly is the benign prostate hypertrophy. It could also be caused by the prostate cancers. Okay, these are because urinary retention and urinary tract infections are high. They occur more, so we try to fix the BPH, whether put them on Flomax or whatever, to try to decrease the size of the prostate so that it doesn't recur. Okay. Otherwise, the chronic cough, constipation, poor tissue quality. There's not much we can do about that unless you can try to increase their nutrition status. Okay. And then poor operative technique. That's on the surgeon. Okay. Those things will contribute to reoccurrence. So we try to optimize as best as we can, getting them on a good bowel regimen so that they're not constipated anymore. Okay, we're treating that chronic cough. Trying to at least. Okay, sometimes we just can't. Sometimes we just have to do it. But we try to optimize them as best as possible. All right. All symptomatic hernias will go to surgery. Okay? All of them. The only time we won't is if the patient is, unstable, they're too sickly, it's inoperable. Okay, the patient dictates that. Okay. But all symptomatic hernias will most likely be treated surgically. Okay. Normally we want them under general anesthetic. We want them paralyzed. We want them to be completely asleep. That's that ET tube through the vocal cords. Okay, this is not just an LMA. This is fully asleep. Okay, we need them to be relaxed. because that's one of the reasons why they're either incarcerated or strangulated, right? Because those muscles are so tense and so inflamed, so we need them to be completely relaxed. Like we saw before, the peritoneum extends through that internal and external ring. Okay, we need to find that hernia sac, whether it's open or laparoscopic. Okay, and we need to try to close that hernia sac or remove it. Okay, but we will always try to find that hernia sac so that it does not reoccur. Okay. When do we pick laparoscopic versus open? Okay. Some surgeons will just always go to laparoscopic. Sometimes it is just surgeon specific. But in terms of like the textbook answer, okay, if this is the first time they've ever had surgery and it is a unilateral, so only one side, they will most likely do it open. Meaning they go through the skin, there's nothing inside, nothing intraperitoneal, okay? They basically go through the inguinal canal, pull up that hernia, push everything, push all the intestines back in. They lay a mesh and or a cone of mesh over the internal inguinal ring. Okay, not the deep, but the internal one, the superficial one. Okay. And what that does is that it makes it so that the spermatic cord can go through, but nothing else can. We close down that defect. But that's through an incision on the outside. Okay? So that's unilateral, and it's the first surgery we've ever had. Okay? Once we have that first surgery done, we can no longer really go open. Why do you think? Once we've already laid mesh, do you think that mesh is going to be easy to get through? No. It scars down, it becomes almost like a different, like, it's a really thick, fascia type material, okay? It's like plasticky in some cases, okay? So once we've already done an open procedure and laid mesh, we are no longer an open option. Okay, we're not going to be able to get through that mesh again in order to take it out and to do a new type of mesh or a different type of closure. Okay, so once they've already had one, then they go laparoscopic. Okay, so when do we choose laparoscopic as our first operation? They have bilateral. Okay, so if they have bilateral, meaning they have hernias on both sides. Okay. It's easier to do laparoscopic and repair both sides versus cutting open two different sides. Okay? And then again, failed unilateral repair. Now, I have these two acronyms here, TAP and TEP. Okay? I do not have them written out. I don't have the definitions written. Okay? I will explain it to you guys. But this is not something that I need you to really know. I just need you to know that they are an option. Okay? So a TAP. This is trans-abdominal. Okay? Going into the belly. Goes through the peritoneum. Okay? Every other laparoscopic that goes into the belly, through the peritoneum, okay, is like this. So basically when they get in, okay, they shine a camera up towards the pelvis, they find the peritoneum, and they actually peel the peritoneum down so that they can get to those rings. Okay? A TEP is a total extraperitoneal approach. Okay? It's really cool. If you guys get a chance to see it, I would. They basically make a belly incision as if they're going to start a laparoscopic, but once they get down to the peritoneum, they actually stick this flat balloon, okay, down over the peritoneum, between the peritoneum and the sub-Q layer, okay, then they blow it up so that it separates. So it's totally extraperitoneal. They don't ever go intraperitoneal, okay? So they basically go through the layers and keep the peritoneum intact so that instead of peeling it down and then they have to repair it, it's just balls down, and then they can see those hernias, those rings where they used for repair. Okay? So just know that they exist. I would try to see both when you see them, so that you have a better preparation for your patients when they're like, well, what should I expect? Okay. But yeah. Okay. When you're looking at this picture up here, okay, the white rod is actually a stapler. Okay, we can actually deploy circular, like twist staples instead of the normal outside staples. Okay, and so it's basically holding up that mesh to the defect on the inside, and we're stapling it in place. Okay, we do that whether it's a tap or a tap. Okay, the last step with a tap though is we have to we have to put that peritoneum back up and re-suture that. Alright, does that make sense? Any questions on that? Are you still with me? Okay. So, this is a good list to know. Okay, kind of what we already went through on how the surgeon and how your team is going to pick whether it is a laparoscopic approach or an open approach. Okay. We have the NICE guidelines for indications for laparoscopic hernia repair versus open. And so we have recurrent hernias, okay, especially those that are a open repair. We have bilateral hernias, need for return to early activities. Okay, that is a big, big part. Okay, we don't have to go through the skin. Okay, with a bigger open incision. Okay, they can get back to activities sooner. Okay, patient has to withstand anesthesia. Okay, personal choice of the patient and or surgeon. Have to throw that in there. All right. Now, complications and prognosis. Okay. The biggest thing, what I want you guys to take away from this is when you're trying to educate your patient, if they do a laparoscopic repair, whether it is a TAP or a TEP, they can go back to whatever they were doing full duty within 15 days. Okay? If they do open, it's about a month. Okay? So if we can get them through a laparoscopic procedure, that's what we're going to do, especially for military members. We can get them back to full duty sooner. Okay? Complications, we can have bleeding hematomas. Okay? I want you to highlight and bold ilioinguinal nerve. Okay? When we do open, okay? This is a big nerve that we cut. We prophylactically cut. If we do not, there are studies shown that you will have, the patient will most likely have chronic pain in that area. Okay? So that is the nerve that we sever. We mean to do it to help decrease their chronic pain. Okay? We can hit the spermatic cord, we can damage anything within those, okay? Veins, arteries, the actual vas deferens. Okay. Recurrence, laparoscopic actually has the higher chance of recurrence versus open. We take that chance. Okay, we get it back to duty sooner, but we try. Okay. All right, femoral hernias. So any questions on inguinal hernias? No? Do we need like a 5-minute break? I'm good?
Push.
Okay, push. Okay. Femoral hernias. So, again, below the inguinal ligament, okay? Within that femoral triangle. Okay, medial to the femoral nerve. Sorry, vein. Medial to the vein. Okay? What is our acronym to know where our femoral artery, nerve, vein, lymphatics lie? Anybody remember? Navel is one, right? So you start out at the hips, you have nerve, artery, vein, empty space, lymphatics. Okay. I'm going to teach you a crude one. Okay. It is. Hopefully I don't offend anybody. Okay. But if you have a hard time to remember that the N, you have to like kind of flip navel, right, on the other side, think venous to penis. Okay? Vein is always closer to the penis. Always closer to midline. That's how I remember it. I said that to a surgeon the other day, and he's like, that's great. Right? Venous to penis, you'll never get it wrong. Okay, so when you're trying to do central lines, and you feel the femoral artery, okay, always go medial to it. Great. You don't have to remember all the other acronyms. Okay? So, although femoral hernias are not as common, they are way more likely to become strangulated and incarcerated. Okay? We tend to see them more in females, although realistically the ratio is pretty similar, but it is more common in females. Okay? Because males have that inguinal canal, they have other areas of defects. We have it more common in femoral hernias. Okay? So you can kind of see here and in here, below that inguinal ligament, okay? Here, below that inguinal ligament, and here, okay, it almost looks like a lymph node. Okay? It could theoretically be, you know, if you don't feel it, you just may see a bulge there, okay? You see a mass there, but you really have to feel it in order to decide on, or throw an ultrasound on it and see if there's bowel there or not. Okay? So, presentation, you're going to have the groin bulge, groin pain. They may be constipated, nausea, vomiting. They could be causing obstruction if it is strangulated. Okay? When they Valsalva and cough, it's going to get bigger. Unfortunately, unless you know the location, all hernias get bigger when you abdominal hernias will get bigger if you Valsalva or cough. Okay, so it's really not a great way to differentiate between the groin hernias and abdominal hernias. Okay, but they're usually not tender. We'll do because we strangulate more, they will always go to surgery. Okay, if they're asymptomatic and reducible, we'll do it electively. If it's already starting to be incarcerated, we cannot reduce it, they're going to go do an emergent or an urgent type of surgery to repair. Okay. So, non-reducible, right, strangulated. Okay, if it's perfused, it's incarcerated. If it's ischemic, it is strangulated. Okay, this is dead bowel. You have nice healthy bowel up here. Dead bowel on the bottom. Dead bowel smells awful. It is one of probably top 5 worst smells in surgery. Okay? So what do you see? Acute abdominal pain, cramping, distension. Okay? You'll have a leukocytosis, so high white count, high fever. When you have bowel ischemia, that leads to necrosis and perforation, so you may have pneumoperitoneum. Okay? If it's strangulated, infarcted, okay, if it is ischemic, okay, you're going to have that necrotic bowel, and all of that needs to be resected. So all of this dead bowel got resected. Okay? This is another one that if you think that it is a strangulated dead bowel case, put some Vicks underneath your nose before you head in. You're welcome. All right. Any questions on femoral hernias? Cool. Let's move on to epigastric. Okay, this is a type of ventral hernia. This is a protrusion through the linea alba above the umbilicus. Okay. Normally we do not see bowel. Normally it is just peritoneal fat or omentum. Okay. Normally it is non-tender. Normally it is easily reducible. Okay. Normally, because there's no bowel involved, you're not going to have an ileus or ischemic. Okay, that fat can become necrotic and cause issues. Okay. And if by chance it does become you know, bowel in there. Just because it normally doesn't happen doesn't mean it never happens, right? You can still have the same type of picture of strangulation and incarceration of bowel if bowel gets in there and you can't reduce it. But normally it's just that peritoneal fat. Okay? Working it up just like you do any other hernia. You do your focused H&P, you do an abdominal ultrasound. Okay? If you still can't figure it out, you do CT of abdomen, pelvis with IV contrast. If it is asymptomatic, you refer to surgery. If it is symptomatic, you refer to surgery. Normally, though, you're going to refer just to general surgery for routine surgery, okay? Routine elective surgery. If they are, this is one of the hernias that if they are a poor candidate, okay, they're not really eligible to go under general anesthesia. Okay, this is not one that we can really do a epidural block for. We can in an emergency, but realistically in an emergency we're going to do general anesthesia. Okay, but if they are a poor candidate for surgery, then we have these lovely abdominal binders. They kind of just, think of it as a corset, kind of keeps everything in. They're not that comfortable. Okay. Corsets are not comfortable. These are elastic. It's going to itch. It's going to sweat underneath it. So a lot of times we have poor compliance because of that. Okay. You also want to make sure that it goes low enough that it doesn't actually constrict around the chest. I would say this is actually too high. Okay. We don't really want it above the ribs because we want them to be able to have that effective ventilation, oxygenation. Okay, we don't want them to be so constricted on their lungs, taking shallow breaths, never gonna work. They're gonna become, have atelectasis, which leads to pneumonia, which then leads to bad news. Okay? Alright. Umbilical hernias. Start at the umbilicus, okay? Very, very common in newborn and lower age children. We normally do not do any surgical repair unless it is still there at 2 years of age. Okay, we let their bellies kind of see if it will be reabsorbed. Okay, these are very rare to incarcerate. Obviously, if it does, then we will go straight to surgery no matter what age they are. Okay, but most of them just spontaneously go away. They kind of spontaneously fix themselves as they grow up. But when you're doing your well child checks, right, and you have a kid who has a known umbilical hernia, or you see one for the first time, a newborn with an umbilical hernia, that is something to put on a list somewhere so that whenever they come in, you are checking that, okay, and you are teaching the parents or guardians how to make sure that it continues to be reducible. And giving them those, ER precautions on like, hey, if the skin becomes really, really red, they're not eating, they become feverish, okay, inconsolable, you can't reduce that hernia, they should go to the ER. Okay. Now for adults, okay, you have multiparity, so multiple pregnancies, if they're obese, they have really bad ascites, okay, if they have intra-abdominal tumors, so anything that is an increase of the intra-abdominal pressure. Okay, you can cause to have that hernia. Okay. All of us, so where our umbilical veins come in, okay, all of us have a tiny little defect right where that umbilical remnant is. Okay, so it just depends on if that gets bigger or not. Okay, for adults, it really takes a long time to enlarge. These may incarcerate. Okay, if that hole is not that big, but the intra-abdominal pressure is high, right, it's going to push contents into this hole, and if it's either incarcerated or strangulated, we're going to have to do emergency repair. Okay. Hopefully we can get them before it actually strangulates, so we can do this laparoscopically. Okay, we go in on the belly, on the sides of the belly, we kind of look up at the umbilical region, pull all those contents back into the belly, and then lay a nice big mesh over the area. Okay? If we have to, we can do it from an out or an open approach. Okay, we make a cut. Surgeon dependent on if they go above the belly button or below the belly button. Push everything back down, and then if it's less than 2 centimeters defect, normally we can just suture that like we would any other port opening. Okay, if it's greater than a 2 centimeter type of hole, most likely you're going to do a laparoscopically so that we can put a nice big mesh in there. All right. So again, operative repair we can do open. Okay, we can do laparoscopic. We're gonna do so this one says infra-umbilical. They can do either. Okay, I've seen both. Infra-umbilical may have better cosmetic because it's below the belly button versus above it. But again, it's surgery. It's surgeon specific. Okay, we're gonna lace those adhesions, take everything down, reduce the omentum, remove any of those, any of the intestine within that. Okay, you see on this bottom picture. Okay, let's start at the top. This top picture is you see kind of this ring above. That's your umbilical hernia. Okay, all of this smuts, all of this intestine and omentum is going up through into that hole. Okay, the middle picture is where they pulled everything out. You can see how big that defect is. Okay, the bottom picture is mesh with those spiral staples, keeping that mesh above, okay, or like holding the back of that hole so that nothing can go through it again. All right. Incisional hernias, we kind of already talked about this. This is something that we cause, okay, whether they have a laceration or we entered their belly at any point. The bigger the operative site, the more herniation risk can happen. Okay, basically it's a dehiscence of the fascial closure. That should not say facial, that should say fascial. There should be an S in there, F-A-S-C-I-A-L. Okay. Things that can cause these. Okay, this is why we kind of say don't do push-ups, don't be lifting any heavy weights greater than 5 pounds. Okay. If they cough, obesity, infection of that wound. So if they have a skin infection, okay, which is why we do the preoperative antibiotics to lower that infection rate. Okay. But yeah, if they pop their sutures on anything that we do to try to close their fascia, they're gonna most likely have an incisional hernia depending on how big the hole is. Okay. If they're symptomatic, we repair it. Okay. If not, we try the abdominal binder again, see how it works. There are certain, there are big incisional hernias that I'm more familiar with when we have abdominal trauma and their bowel is so edematous from either not eating or just the infection or you know, their trauma in general. Okay, sometimes we will actually leave the fascia open and have them close kind of secondarily, which is absolutely nuts. Okay, I tried to find the pictures but I couldn't. Otherwise, we try to leave it open for a while and try to slowly close that defect up. If we can't get the fascia to close, then we'll just at least close the skin. And that's what we call a planned ventral hernia. Okay, it's still technically an incisional hernia because we did the initial cut. So we'll look at wound dehiscence and stuff. But if we can't close the fascia for whatever reason and we just close the skin, right? We're not closing down that hernia space. We're not closing down that linea alba. Therefore, most likely we will cause a, well, not most likely, we will cause a planned hernia. Does that make sense? Okay. Wound dehiscence. Are they a type of hernia? Kind of. Okay, it's still a breakdown of that fascia. Okay. We'll talk more about wound dehiscences in the next block when we do wound care. But this is an actual patient of mine from a few years ago. You'll see, okay, you can kind of look at this picture, right? There's these blue things, those are the sutures. And then right here in the middle, okay, right here in the middle, you'll see that on the medial side, or on the right side to you guys, okay, that suture is no longer attached to the other side. Okay, that is a wound dehiscence. That is a fascial dehiscence. Okay, that suture trying to keep that fascia together, that abdominal fascia, just disintegrated and popped open. This guy went back to surgery and we left him open. Okay, any type of wound bed dehiscence, most of the time we have to take him back to surgery to do an operative type of washout. Okay, so if you are following these patients up on the floor, okay, and you see salmon or yellowish pinkish type of fluid coming out of it, that is peritoneal fluid. Probably not good. Okay, make sure that you inform your surgeon or your surgical team that you think that there's an issue. Okay. Most of the time, like I said, they must return to the OR for fascial closure before they eviscerate. Okay. The only thing keeping this guy intact are those sutures. Those sutures continue to pop up and down because of infection, because we need to wash him out. His bowels are just behind that. He's going to eviscerate. Okay, so we try to control that evisceration in the OR and open them up and have a delayed closure. Okay, if you see somebody, which I've seen, an acute fascial dehiscence, they eviscerate. Right, it's emergent surgical evaluation. They have to go back to the OR. We can't just have bowels just open to the air. Okay, our bodies do not like it. Okay. At that point, we'll put what we call an ephthera in. We wash everything out, we open everything up, cut out any dead tissue. Then we put what's called an ephthera, which is a different type of negative pressure wound vac. Okay. You don't leave it in for more than like 48 hours, but it basically goes above the intestine and into like around the intestine underneath the skin, and it's basically a big old wound vac. It's really cool. Okay. If I can find some pictures for that other block, I will. Okay. And then, like I talked about before, the delayed fascial dehiscence, it's basically an incisional hernia where if that fascia like this opens, urgent versus emergent, make sure you talk to the surgeon. Okay. If they show up in your clinic for a post-op appointment and they come in looking like that, that is not we'll see at the next appointment, let's try to do some, packing and that. No, it's calling the surgeon in and saying, hey, I think this guy needs to go to the OR, which has happened a lot. Okay. What is this on the side of the picture? What do you think that is? It's a stoma. If it's in the right lower quadrant, which one is it normally? Is it a colostomy type stoma or an ileostomy type stoma? Ileo. Right, ileo. Can we have colostomies on the right side? Yes. But most of the time, especially with how small that looks and how smooth those edges are, that is most likely an ileostomy. Okay. Alright. Any questions on dehiscence? No. Cool. Next. Traumatic hernias. I told you we'd get to it. Alright. So these are a violent ripping of muscle from bone. Okay, from large, blunt external forces. You're not going to get this from a penetrating wound unless it's like a machete, right? But most of the time it's going to have that blunt type of abdominal injury, which causes that pressure to be expended somewhere. And the most likely is that area on the flanks, right above the inguinal or the iliac crest. Okay. We do a CT scan to confirm, so you can see here. Okay. Let me stand back here so you guys can see. Okay. So this is the CT scan. This is a axial view. Okay. This is the right side. This is the left side. Okay. Right side, left side. So see on this left side, you have these abdominal muscles right here. Okay, they kind of connect to that transverse process all the way up to where your rectus is. Okay, and then on this side is just non-existent. Okay, you have intestines spilling out. So intact this side, muscles intact, no muscles on this side. Okay, and all that's intestine. This is a frontal view. You can see on this side, all your muscles there are intact, your ribs to your iliac crest, versus on this side is just non-existent. Okay? Primary repair should only be taken care of when the patient is stable. Okay? So if we have a patient who is dying due to some other thing, okay, we will fix that other thing first, get them through their initial trauma, and then have a planned repair with mesh later on. Okay, it is still something we will repair, but we don't necessarily repair it initially on that initial first OR trip. Okay? If we see somebody who has a traumatic hernia, whether or not they have any other abdominal type of symptoms, okay, we still do an X-lap just to make sure that there's no other organ and or intestinal injuries. Just because it is, if you have enough force to rip muscle from bone, you more than likely have other injuries in there. All right, moving on to diastasis recti. It's technically a type of hernia, but it's just a widening of that linea alba. It is not a defect. Okay, so theoretically, if they have this, they can either decrease their obesity, work out and strengthen their core after pregnancies, to try to increase that core strength. Okay, like I said, technically not a hernia, right? It's not a defect in any tissue. It's just a widening or loosening of that tissue. Okay, part of the differential. Some people might consider it a hernia, but it's really not a hernia. Okay. Big thing is, if they lift their head, so they're laying down, they lift their head, it will protrude. Okay. We don't like to repair these. Okay. We don't like to repair these. Okay. It is basically a total abdominal reconstruction. If we can get them to a point where they can use PT and or exercise to try to or strengthen those supporting muscles, we try not to repair these. Okay. All right. All the differential diagnoses. We're almost done. Okay, almost done with this one. Do you need a break or do you want to just push? Push. Push. Got it. Okay. So. Sports hernia is not a hernia. Not a hernia. Okay? It's called a hernia. Don't know why. Not a hernia. But basically, it is a series of micro tears within these muscles. Okay? A lot of times it'll manifest as like, I think I have a inguinal hernia or something, but we can't ever really prove it on CT, ultrasound, on exam. Okay? We do a surgery for a hernia. Normally a cap or a TEP, right? Sometimes they get better. Like a miracle of surgery. We may not actually leave any mesh, but just because we actually do surgery, sometimes they just get better. Okay? But that's really after 8 weeks of treatment that has not resolved any of their pain. Okay? And, you know, conservative treatment meaning lifestyle limitations. Really, I learned yesterday that no other services have Lindu, which is crazy. Okay, I don't even think you guys know what Lindu is.
No.
No, it's basically limited duty, meaning that they're on a profile, they can't do certain things, and the Navy's just okay with it. And it's crazy that you guys don't have that. You have something like it. You do not have. Does the Army have it? You guys have Lindu?
Called something
You have
different.
profiles, right?
Yeah.
Yeah, I was talking to Dr. Klein, and she was like, yeah, no, we don't have that. You guys have to talk to your whoever is rating it every 30 days. We can do it for 6 months. It's just different. Okay? But anyway, once they fail, okay, that's when we normally do some sort of surgery to try to see if we can see a hernia. And really it's an exclusion diagnosis, like we really can't prove there's anything else going on, so we do a little diagnostic lab, see what's going on in there. Sometimes we find something, most of the time we don't, and we close and they get better. It's weird. Alright, hydroceles. So, okay, you have that process vaginalis, right? So instead of intestines, it's fluid. Okay? Okay? You have a buildup of fluid around that testy. Okay? Could be both, it could be one. Could be from infection, could be from trauma, could be from a testicular tumor. Okay? Most of the time it is congenital. Normally they are non-tender. It will transilluminate. Does everybody remember what transilluminate means? Okay. Yep, you put a light up next to it and it lights up. Okay, nice and bright. Do not attempt to aspirate these. Okay, send them to a urologist if they are symptomatic. Not a nephrologist, a urologist. Okay, get that ultrasound and send them to urology if they're symptomatic or if they want to do something about it. Okay, for the elective surgery program. Alright, epididymitis. Okay, this is pain and infection and inflammation within the epididymis. Okay, normally it is testicular pain, not groin pain. It's usually very acute. Okay, we see this more so when they have an associated prostatitis or recent vasectomy. Okay, if you see this, okay, if they're a young male, please test for STIs. Okay, STIs are the #1 cause of epididymitis in young men. If it is an older man, you still do the STI panel, but it's most likely some other thing. Okay, so young man, we're going to actually do an empirical treatment of STIs with antibiotics. For older gentlemen and monogamous type men, they're like, no, nothing could absolutely happen. We're going to just treat for gram-negative rats. Okay, so there's the two different types of treatments for that. All right, spermatocele. So this is a fluid-filled mass or cyst next to or attached to the epididymis. Okay, normally non-tender, can become large. If it becomes symptomatic, then you can confirm with an ultrasound and send to urology. Okay. Varicocele. Okay, these are the dilated veins of the scrotum, bags of worms. This is one of the #1 things that gets confused with an indirect hernia. Okay, if the varicose veins are actually big enough, they could theoretically look like intestines. Okay, but it's not intestines, it's a venous structure that is enlarged. Okay, this is where you have that bag of worms. Okay. Normally isolated to the left. Later on in life, the right likes to join in. Okay, if it's the right, you have to look for any masses that are including the spermatic cord on that side. Okay, most of the time it's just on the left though. Okay, you can see these in infertile men. Okay, so we try to fix these in young men who are trying to have children. Okay, blood around the testes means increased temperature, means decreased fertility. Okay, so if they want to be increase their fertility status and or they're symptomatic, you can send to urology to fix. Okay. Testicular cancer. Okay. You have a mass on the testicle. If it is a solid mass, cancer until proven otherwise. Okay, urgent urology referral for ultrasound and surgery. Okay, do not sit on these. Do not try to send them to an outpatient ultrasound. Okay, if you see a solitary mass that's non-tender, I would send to, I would actually probably call the urologist and say, hey, I have this guy with this testicular mass, I think they need to see you. Most likely they'll get him in that week. Okay. Torsion, extreme testicular pain. Okay, they'll be nauseated, they'll be vomiting, they will be sweating. Okay, this is the most tender, painful situation a male can go through. Normally it's after strenuous activity, something caused it. Okay, it's not necessarily just going to be from like sitting on the couch doing nothing. If you suspect it, okay, you have a high riding testicle, do an urgent ultrasound with Doppler, okay, call urology. In EMED you'll learn how to open the book. Okay, Okay? In some cases, if you feel like you can open the book, which is you go from medial to lateral opening the book. Okay, so if it's a left side, you're staring at a patient, you're opening that way, or that way, you're opening a book versus closing the book. Okay. If that doesn't work, obviously have a urologist on standby. Okay, they're most likely going to go to they are going to go to the OR and either do an orchectomy. Okay, if it's necrotic, like this picture down here, lovely purple. Okay. If it's viable, they will reperfuse it. They'll wait a couple minutes, make sure that it is just that it was ischemic, but as long as it pinks back up, okay, they'll actually tack it down with an orchiopexy. Okay. If they can't, if it doesn't reperfuse, they get an orchectomy. Everybody remember what those words mean?
Cut out.
Orchectomy takes out, orchiopexy tacks down. Okay?
Bilateral. Oh.
Yes. Alright. We're done. Any questions?